Alright guys, we're going to show you how to properly put a King Airway. First thing, this device is being placed only in cardiac arrest situations in New York City per the protocol. Thus, that means you already tried to do 2 attempts of endotracheal intubation and you were not successful. What I urge everybody to do is always position your patients appropriately, and for any type of advanced airway management, you always want to have auditory meatus, that's the ear hole, align with the sternal notch. So if I draw a line, these 2 points should meet, right? We tried our 2 attempts and we were not successful. The CPR is commenced, right? And we're gonna go back to BLS airway management, 2 breaths to 30 compressions. So, right, just to emphasize a few things, right? OPA is measured from the corner of the mouth to the angle of the jaw. We're gonna do a cross finger technique when you insert it. And then you're gonna go straight down. And then the patient is gonna be ventilated at a rate of, so in this case, at a ratio of 30 compressions to 2 ventilations, because CPR is ongoing. And we're gonna place this at 15 liters in order to deliver the appropriate O2 concentration, right? So 2 breaths, right, are given and CPR is being commenced. My partner here is gonna act out the 2 ventilations while I prepare my King tube for advanced airway management. So a few things that I want to talk about here, right? If you try to do this, you probably already have your laryngoscope blade handy. This may facilitate in inserting this device. The reason why is I personally do not like to put my fingers in anyone's mouth. There's a possibility, right, that anyone can bite down. So this may be used in assistance in order to open it. If, let's say, you did not have this and you had to use your fingers, yes, you could perform tongue lift and jaw lift. This device is via blind insertion. Now, the most important thing per the manufacturers, once you do the jaw lift, you have to insert that the connector is at the tip, right, of the teeth. And the reason why is as follows. Some patients are tall and some patients are not so tall, they're short. And this is sized based on patient's height. And what they say is, if you insert as deeper as you can, you inflate the balloons, then you could pull back the device to give you the optimal flow to the lungs. You cannot do this in reverse. You cannot inflate this device and then start jamming down the patient's throat, because that can cause damage to the patient. So what the manufacturer says, insert it to the base, inflate it fully. They give you in the packaging a 60 cc syringe, 60 ml syringe. And you notice that if you look at the tube itself, it tells you a range between 50 and 70. And the reason it's between 50 and 70 is because when you pull back, right, in order to give you optimal lung volumes, you may need to give it a little bit more air if you hear there's a leak, right? This is the reason for that. Again, rationale for this is a taller person from the teeth, right, to the laryngeal inlet will be more space, so his laryngeal inlet will be more inferior, as opposed to somebody who is very short, their laryngeal inlet will be more superior. All right, so that's one important thing. Now, so I have my laryngoscope here. I'll show you both ways how to insert it, with laryngoscope or with your fingers, right? So they're doing compressions. I'm ready. I have my supplies, right? So what you will need, you need your King Airway, you need your syringe, you need a securement device. So here we have a commercial Thomas tube holder, or you could also employ tape. I'll show you how to do both ways. One thing though, with the commercial tube holder like Thomas, you have a bite block in place, so you're not worried about bite block. Somebody with tape, I also want to make sure that my OPA is in place. The reason why is if they start chumping down, I don't want them to compress my King tube, my King Airway. You also want to make sure you have your suction nearby in case the patient does vomit. Some contraindications to use this device is somebody who has an intact gag reflex. We're never going to use this. Anyone who has any type of disease to the esophagus, if you know about it. And another reason why you would not want to use this device if they ingested some caustic substances. So if you have no idea about that, and the patient has no gag reflex and you have failed 2 intubations, you have your indications, right? So what we're going to do is I'm going to ask my partner, right, after your next 2 breaths, please remove the device. I'm going to take out my OPA So in this technique, I'm gonna show you a lift, right, tongue, jaw lift. So what you're gonna do is you're gonna come in the mouth like this, you're gonna lift it up towards the ceiling. I'm gonna come at about 45-degree angle from the side, right? As I pass the tongue, I'm gonna turn my King tube and I wanna advance it all the way down that the teeth are in line, right, with my connector. At this point, I would inflate it. The other way to show you with the blade, you would do it the same way, like you're instrumenting the airway. Come in, right, elevate. And the way this device is designed, it's not designed to go into the trachea, it's designed to go to the esophagus, and it will follow the natural curvature. All you're doing with the blade is basically displacing the tongue. So come in, right, and advance until it's at the teeth. At this point in time, what I'm going to do is, CPR is still commencing, I'm going to go ahead and inflate my balloon with 60 cc's of air, right, and then I'm going to connect my end-tidal CO2, which I have right there. Thank you. And now what I'm doing is, and connected to the monitor, so as my partner is ventilating, right, what I'm doing is I'm observing for the chest rise. So you guys notice there's not real good chest rise. That means that the oral pharyngeal balloon is blocking the laryngeal inlet. So what I'm going to do is I'm going to start drawing it up, right, and I'm looking at the chest. Now I see I have good chest rise, and I also want to listen if there's any leaks. So I do hear leaks, right? I do hear leaks. So I'm going to do is I'm going to take a little bit of air and I'm going to make sure I correct that problem, right? Right? So now I hear no air leaks. My tube is positioned. I'm watching my end-tidal CO2. If we're in a rest situation, end-tidal CO2, ideally I want to be greater than 10. So in order to swap my compressors and making sure they're doing a good job, right? So I'm monitoring my end-tidal CO2, right? I would also auscultate that I have positive bilateral lung sounds and I have negative epigastric sounds. Once I confirm that I have positive breath sounds, negative epigastric sounds, my end-tidal CO2 should be what it should be for this situation. I'm going to go ahead and use my commercial tube holder, and I'm going to go ahead and secure my tube. Right? Make sure my straps are tight. So now, if let's say this patient had very excessive gastric insufflation because of the BLS maneuvers on the scene, who got there before, and perhaps because of the epinephrine surge, they pumped a lot of air into the stomach. It's also a possibility, you know, the guy ate right before this. Nobody goes into cardiac arrest on an empty stomach, so his stomach may be very full, and I need to decompress it. The reason why I need to decompress it will facilitate better tidal volumes for me when I'm ventilating, and less chance of gastric contacts coming up and patient aspirating. Now, no tube, even the endotracheal tube, will prevent from aspiration. There's always a possibility of some stomach contacts going in there. However, this tube goes into esophagus and it's inflated, so it does give you some protection. But to make sure that we don't have any excess going into the lungs, I want to go ahead, use my silent sump in order to suction, right? So just to make sure you guys understand, this is not tracheal suctioning. So this tube will actually go into the stomach because of the secondary lumen. How we're going to size it, because this is an oral gastric tube, what I'm going to do is I'm going to find left costal margin, and from the left costal margin, just below it where the stomach sits, I'm going to go right to the tip of the ear, and then I'm going to go to the top of the device. So here I'm looking at 75 markings. So I know that once I reach the 75 marking, I am in the correct location to perform my gastric decompression. So what you want to do is you want to connect this end to your suction unit. So we said this goes into air. So if you have one of those tubes and you don't want to get any stomach contents on yourself, you could tie this off. Because the purpose of our suctioning is to decompress the stomach. We're not there for intermittent suctioning, right? We want to get the whole thing. So I said 75. I'm going to use a lubricant, right, to lubricate this. And I'm going to go into the secondary lumen here, and I'm going to advance it, right, until I have 75. So as you guys noticed, right, my tube has gone into the pouch, and it has protruded through the pouch, which I could see here. Right. Then I'm going to go ahead and turn my suction unit, right, and tied off this end, and I have all the stomach contents going up, right? So I have evacuated the stomach, right, and now my ventilations are working better. So you would remove your suction tubing. Now, let's say you wanted to exchange for the endotracheal tube. Now, in the field, when you're working a cardiac arrest, and you have good ventilation, good oxygenation, there's no resistance, you basically have time. Your airway is secured with advanced airway. Thus, I would not recommend exchanging it for the endotracheal tube. Even if you get ROSC back, that's not the time to do this. You want to take him to the hospital where he needs other care. Perhaps a patient had a ST elevation and needs a stent. You don't want to waste too much time. But I'll show you a way, if you wanted to exchange this, how you go about doing it. Now, you probably seen on the websites or read somewhere that you could use endotracheal tube introducer or a bougie. You could slip it in, right? Take off the bag, like so. Slip it in, and then we saw prior that it will come out, right, through that opening and go into the trachea. However, sometimes it may not go through there, and most importantly, this is blind. I don't know what's going on for this patient, so I would never advise for this procedure. What I would advise to do is have the bougie nearby. That's one, right? Remove your securing device. Have your partner, right, do the airway management as he would. So whatever the scenario calls for it, let's say he's bagging one breath every 5 seconds if you got ROSC. The next step what you will do is you will take your syringe and you will deflate the tube, the balloons here, right? So even though it's not optimal, the patient is still being ventilated and still getting oxygen. The next step what I would do is I'll have my blade ready, and I have my bougie ready. So this is what I would do, right? I'll ask my partner just to move his fingers, right? Move this to the side, right? And you could ventilate, right? So take my gum bougie, and I do see the vocal cord. So the key thing here is I visualize them. Now, I visualize them, and another important thing, I feel hold up. I felt the rings and I feel hold up. Now, what I can do is, right, I can have my partner pass me the endotracheal tube. I'll remove the stylet, and what we can do is we can use like a Salinger technique, right, in order to guide it over. Now, here, ideally, what you want to do is you also want to have your blade in place when you do this. So hold the top for me, thank you. So I come in, I feel some resistance, I pull back, I go forward, perfect. Go ahead. Inflate my pilot balloon, 10 cc's, take this off, have my partner switch. All right, so I'm gonna go ahead, make sure that right, looking at my end-tidal CO2, auscultating epigastric sounds, auscultating bilateral breath sounds, right, seeing good chest rise, right, and I confirm, then I can secure my tube. So if you had to change it out, this is how I would do it. But be forewarned, if you fail 2 attempts and you had to put the rescue device, the chances of you being successful is highly unlikely. Plus, this is very quick to put in, and you're able to ventilate and oxygenate, so you have time. So you already have an advanced airway in place. All right. Now, one other thing I would like to show you guys is how to secure it with tape if you did not have a commercial tube holder. So let me remove this. So we're going to remove the endotracheal tube. I'm also going to remove this device, deflate my cuff fully. Okay. So let's say you did not have this device here. Right. So we're back at BLS airway management. Right, you lay out all your equipment, right? And what you will need for this is you will need your tape, which is here, right? So the technique that I'm gonna do is I'm gonna use tape, and what I'm gonna do is first I'm gonna put a bridge on the nose, right? Bridge on the nose. I'm gonna go around the tube, go behind the neck, come back, go around the tube again, and secure my bridge. And very importantly, I'll leave my bite block afterwards. So if the patient was to come back and had ROSC, I don't want him chomping down, right? So I tell my partner, right, I'm ready to place my king tube, right? You could use your blade, or you could do the jaw lift. Come in from the 45-degree angle. Again, the connectors at the teeth. 60 cc's. I'm going to inflate it fully. My partner starts ventilating with capnography in place, and I'm going to auscultate. All right, I see no chest rise. That indicates that I placed it too deep. I'm going to pull on it slowly until I am at the laryngeal inlet. All right, we'll pull a little bit more. Okay, a little bit more. Now I hear there's a little leak, so I'm going to go ahead and correct this by inflating my balloon a little more. Perfect. I hear no leak. I auscultate it again. I have breath sounds bilaterally. I have negative epigastric. I'm looking at my end-tidal CO2, whatever it's reading. If it's in cardiac situation, I want it above 10. If we have pulses back, I'm monitoring my end-tidal CO2. Now comes time to secure my device, right? So I want to make sure, right, I do have my bite block in place, that if the patient were to chomp down on the tube, it's in place. Get my tape, I'm going to build a bridge. Go around it. Now, very important thing here is when I go behind the neck, I don't want to create like a ligature. So I want to be ideally behind the occiput, not the neck. Come back over the bridge. Go the other way and put down this second bridge. I leave my pilot balloon accessible. Make sure that I do not constrict any vessels on the neck. I'm on the occiput. I have my bite block in place. I reconfirm my lung sounds. I reconfirm negative epigastric sounds. I am watching my end-tidal CO2 waveform. Right? So this is the way you would use a rescue airway device in these situations. All right. Thank you.